हाँ उनका ही सेशन है पहले।
Okay, ma'am. Shall we start, ma'am?
Yes, yes.
Good evening, everyone. On behalf of Ratlam Obsangani Society and Ujjain Obsangani Society, I welcome you all on this very important and very current topic. To start with, I welcome our first guest, Dr. Vidya Thobi ma'am, for her talk on medical termination of pregnancy amendment 2021. Welcome, ma'am.
Madam, you are muted.
Yes. Thank you very much, Dr. Neha, for those kind words, and thank you, Ratlam and Ujjain OBGYN Society. And at the outset, I thank our President, Dr. Shanta Kumari and Dr. Madhuri Patel for this RAC program. And let us go with the topic itself. I would like to share my screen. Kindly allow me to share my screen. Yes. Hope my screen is visible to everyone.
Yes, ma'am, it is visible.
Yeah. So we know about the safe abortion, and in India is the only country where the abortion is legal, and now we have added a second word, that is respectful abortion care. So in this module, we are going to talk about medical termination of pregnancy, that is MTP Amendment Act 2021, which has been revised in last year. So here we will be taking a closer look at what are the new laws and various changes in the various rules which have taken place in 2021. So why we talk of these amendments? We all know that unsafe abortions has led to many mortalities, morbidities, and it also hampers the women's and girls' full participation. As I know that I was a postgraduate student, then we used to get many septic abortion cases also. Now they have become lesser also. 8% of the maternal deaths per year occur due to abortion, and it is a third leading cause of maternal mortality. And nearly 2 out of 3 of these abortions are performed and deemed unsafe. Nearly half of pregnancy-related deaths are women and girls under 24 years. So when the abortion is considered safe, so we know about the WHO definition of safe abortion. That is, it is done by appropriate methods and by trained person. So when it fulfills both the criteria, that is by appropriate methods and trained person, then we call it as a safe. Then if only one criteria is met, either the appropriate method or by trained person, then it is less safe, and totally unsafe when both are not followed. That is, it is not followed, that is appropriate methods, and it is not done by trained person. The medical termination of pregnancy is amended 2021, and it is mandated by law, safe, comprehensive care. Now, what are the various laws' aligned features? So one is the modification in the requirement of provider. So earlier, what was there? The requirement of opinion of one provider for MTP up to 12 weeks. Now, what is the amendment now? The requirement for the opinion of one registered medical practitioner for termination of pregnancy up to 20 weeks of gestation. So it was 12 weeks, now it is 20 weeks. Then there was a requirement of opinion of 2 providers for MTP up to 12 to 20 weeks. Now there is a requirement of opinion of 2 RMPs for termination of pregnancy from 20 to 24. So up to 20 weeks, we require only one registered medical practitioner. Then up to 24 weeks, two RMPs opinion is required. The potential outcome is increase in the number of facilities, especially in the public sector like primary health centers, which is eligible for service provision till 20 weeks. Now, what is a modification for the vulnerable group of women? Earlier, the MTP was permissible beyond 20 weeks only when it is immediately necessary to save the life of a pregnant woman. Now, in amendment in 2021, it is enhanced upper gestational limit from 20 to 24 weeks for special or vulnerable categories of women, and further, the enhancement for the birth defects not compatible with life on medical board consensus. So what is a potential outcome? Again, there is an increased access for vulnerable women to safe and legal abortion services, which is defined by rules. Committee includes the violence victims, minors, amongst others. Now, modification of birth defects and congenital anomalies. What does the previous act says? This act had a provision for termination of such pregnancy only up to 20 weeks. Whereas in 2021 amendment, the upper gestational limit does not apply in case of pregnancies with substantial fetal anomalies, which are diagnosed by the medical board or radiologist, and there is a consensus between the three. The potential outcome is there is increase in the access to safe legal abortion services, who often seek service late beyond legal limit for termination of pregnancies with substantial fetal anomalies diagnosed late, thus the reducing unsafe abortions and court cases. Now, what are the modifications related to marital status? The condition for a failure of contraceptive was applicable only to the married woman or her husband. But here, the condition of failure of contraceptive to be extended for any woman or her partner. So even unmarried girl can also claim that we can claim tell that this termination is done on the grounds that there is a failure of contraception. Potential outcome is increased access to the safe and legal abortion for any woman, irrespective of her marital status, especially with upcoming changes in the legal age of marriage. It is an important advancement for increasing access to safe abortion. Now, what are the insertion of new clauses for strengthening privacy? Now, Medical Termination of Pregnancy Regulation Act, that was 2003, mentioned that information should not be disclosed except under authority of law. Here is a new insertion now. The name and other particulars of the woman whose pregnancy has been terminated shall not be revealed except to the person authorized by any law for the time being in force. So what is again outcome is the increase again in the privacy and dignity of women, provide respectful bias-free services, including counseling and contraception. So this is very important because earlier we used to talk of respectful maternal care. Now here we are talking of respectful abortion care. Now here we prioritize the confidentiality and safety. Name and other particulars of any woman seeking abortion to be confidential except to a person authorized in any law for the time being in force, and the ground of failure of contraceptive has been extended to a woman and her partner. So this is very important change. Now, rules under MTP Amendment Act 2021 defines the special or vulnerable category of women eligible for extended gestational period for termination of pregnancy from 20 to 24 weeks, and the norms for the registered medical practitioner whose opinion is required for termination of pregnancy at different gestational age, and the power of functions of medical boards like which consist of OBGYN and pediatricians plus radiologists whenever available, formed for each state and mandated to provide timely evidence-based decisions. So these are the three inclusions in this rule. Now this is what we see. Now, special category of women eligible for MTP between 20 to 24 weeks. What are they? First one is a survivor of sexual assault, rape or incest. Second one is woman with pregnancy in humanitarian setting disaster, or any emergency situation as declared by government. Third one is change of marital status during ongoing pregnancy, widowhood, or divorce. Fourth is women with physical disabilities like major disabilities as per criteria under Disability Act. Fifth is mentally ill women, including mental retardation. Sixth is minors. And seventh is fetal malformation that has substantial risk of being incompatible with life, or if the child was born, it would suffer from such a physical and mentally abnormalities to be seriously handicapped. So these are the 7 important special categories when we think of termination between 20 to 24 weeks. Now, second is what are the norms for registered medical practitioners? RMP defined in the old act as MBBS or more with an any means first one is medical practitioner who assisted 25 cases of MTP, of which at least 5 are done independently in the hospital, and the medical practitioner who has completed 6 months of house surgery in obstetrics and gynecology, or medical practitioner who holds postgraduate degree or diploma in obstetrics and gynecology, medical practitioner who has experience of at least 1 year in the practice of obstetrics and gynecology. Now, under the amendment of this rule 2021, an additional category of provider has been added for termination up to 9 weeks with medical methods. Now, medical methods are used, but they should also have certain experience. Now, for 9 weeks of medical methods, if you want to use, then you should have experience of in the practice of obstetric and gynecology at any hospital for 3 months, or training with the performance of 10 cases of MTP by medical methods under supervision of RMP in a hospital established or maintained or a trained institute approved for this purpose by government. So for medical methods use also you should have some training. The second thing is the norms for RMP whose opinion is required for the termination of pregnancy at different gestational age. Till 9 weeks, experience and training which is required for RMPs, experience at any hospital for 3 months in the practice of obstetrics and gynecology, or has independently performed 10 cases of MTP by medical methods under the supervision of RMP in a hospital established or maintained or a training institute approved for this purpose by the government. That is the first one. Or a practitioner who has assisted a RMP in performance of 25 cases, of which at least 5 have been done independently in the hospital, or a practitioner who holds a postgraduate degree or diploma in obstetrics and gynecology, a practitioner who has completed 6 months of house surgery in obstetrics and gynecology, and a practitioner who has experience at any hospital for a period of not less than 1 year in the practice of obstetrics and gynecology. So these are the norms of RMP whose opinion is taken as granted. Now, second one is, this is still one, after that 12 weeks. 12 weeks, you have a different, you should have a experience and training and requirement for RMP as follows. Again, the practitioner should have performed at least 25 cases of MTP. 5 should be done independently in the hospital. PG degree and diploma in obstetrics and gynecology, or 6 months of house surgery in obstetrics gynecology, or 1 year practice in obstetrics and gynecology. So till 12 weeks, again, one opinion of, as we have talked of, opinion of one RMP is required. Now, up to 12 weeks, from 12 to 12 weeks, 20 weeks, again, a PG degree of in OBGYN, PG diploma in OBGYN, 6 months house surgeons in OBGYN, and 1 year practice of obstetrics and gynecology till 20 weeks. When it goes beyond 20 weeks, again, you should have a PG degree for obstetrics and gynecology and 1 year practice in obstetrics and gynecology. These are the norms. Now, beyond 24 weeks, when we talk of beyond 24 weeks, a practitioner again should have a PG degree or diploma OBGYN and a practitioner, he should have a certificate, but plus additionally, the termination should have an opinion of medical board is required. For termination procedure, when advised by this medical board, it should be carried out with all safety precautions along with appropriate counseling and at approved place. This is very important. So what is the composition of medical board? It should have at a district level a gynecologist, a pediatrician, or radiologist or sonologist. And what are the powers of these medical boards? One is to allow or deny the termination of pregnancy beyond 24 weeks of gestation only after due consideration, ensuring that the procedure would be safe for the woman at that gestational age, and whether the fetal malformation has substantial risk or it being incompatible with life, or if the child when born would suffer from such a physical and mental abnormalities to be seriously handicapped. And it should be co-opted with other specialists in the board and ask for any additional investigation if required for decision to take on the termination of pregnancy. Now, third is the medical board should examine the woman and her reports who would approach for the medical termination of pregnancy, give the opinion of the medical board in the form D, with the regard to the termination of pregnancy or rejection of request for termination within 3 days of receiving the request for the medical termination of pregnancy, and to ensure that the termination of procedure when advised by the medical board is carried out with all safety precautions along with appropriate counseling within 5 days of the receipt of the request for the medical termination of pregnancy. This is very important. Otherwise, whenever the patients come, if it goes beyond the whatever the limits, then it becomes difficult for the termination of pregnancy. Remember, Foxy had played a very important role to ensure that there are functional medical board in every state as stated in MTP Amendment Act. Now, for this, again, at the end, I must say that registration for this, whatever webinar is going on RAC, very important is a pre-test, post-test, and don't log out, because important is post-test and feedback. Then only your certificate will be awarded to the participant on attending the training and submission of registration, pre-test, post-test, and feedback. And I thank immensely for this inclusion of mine in this important RAC training program. Thanks again, Ratlam and Ujjain OBGYN Society. And if any queries are there, I'm putting my mail ID for the chat box. Anybody have queries, they can just mail me, because I have one traumatic PPH case. So I have to leave early. Thank you very much. Thank you.
Thank you very much, ma'am. Thanks for the very informative talk. And thank you so much. You have a case of PPH and still you are sparing time here.
No, my assistants are there and nothing, just I have to look into, because we know we pay our all Shraddhanjali to recently Dr. Sharma Archana. We are really stuck up with this. So everybody is scared to handle any PPH case. So as a support, I have to go and see. That's it. Okay. Thank you. Thank you very much.
Thank you. Thank you, ma'am. Thank you so much. All the queries are welcome. If anyone has any query, please post in the chat box. We'll have the discussion later. Thank you, Vidya ma'am.
Thank you. Thank you.
I would like to invite our second speaker, Dr. D. Geeta ma'am. Ma'am, are you there? Hello, welcome, ma'am.
Good afternoon, ma'am. Can I have my PPT? Dr. Anjali, can you project? My topic is safe abortion. I'm from Tamil Nadu. I'm past Secretary Oxy. Good afternoon, all. Ma'am, can any one of you, if you have, can you project the safe abortion PPT?
If Anjali ma'am is not doing, shall I?
Yeah, ma'am, you can.
You have it? You can start it. I was also trying, actually. I was just about to share the screen.
Ma'am, please, ma'am, if you can.
Yeah, just give me a minute.
Yes, sure, ma'am. this RAC and DIRA projects are going on very well, like on national level, and are good topics selected.
Yes, ma'am. Very useful topic.
Useful
Day to
topics.
day, we see lot of cases.
Just give me
Especially the minor unmarried. There is a lot of confusion when an unmarried lady comes to us. No.
Yeah, it's visible, ma'am. Put it as full screen.
Yes.
Thank you, Anjali ma'am.
Urgently, I came from hospital.
Just a minute. I'm just about to do that.
Yeah, ma'am.
Yeah. Is it okay now?
Yes,
Okay,
ma'am.
Yes, Dr. Geeta, go ahead. Yeah.
next slide, ma'am. I'm going to discuss about the existing guidelines. What are the pre-abortion assessment, medical and surgical methods? Next slide. This is WHO global guidelines on safe abortion. Next slide. This is a roadmap to WHO safe abortion guidelines from 2012 to 12 to 19. Next slide. This is MOHFW national guidelines on safe abortion. And just now, Dr. Vidya Madam was telling the change of law from 2020, new MTP Amendment Act, the Gazette of India. Next slide. All guidelines have 3 key areas in management of abortion safety: pre-abortion care, abortion care methods, aftercare and follow-up, including post-abortion contraception and counseling. So decision making is important. Pre-abortion counseling, how do we do? Assessment and counseling. Next slide. The components of pre-abortion assessment for women seeking first trimester abortions. As we all know, history should be taken in detail. Then general physical and pelvic examination, laboratory and other investigations, decision-making information on abortion procedures and counseling. Next slide. Gestational age determination by LMP and physical examination. All of you are aware, I think. Next slide. What are the pre-abortion investigations we should not do routinely? Tests that may be performed as per individual risk factors on findings of physical examination. Pregnancy test we have to do if it is not confirmed. Hemoglobin or hematocrit for suspected anemia. RH testing where RH immunoglobulin is available for RH negative women. HIV testing, STI screening usually performed during the pelvic examination. Other laboratory test or as indicated by medical history. If they have any complaints, you can do this renal function test, liver function test, etc. Ultrasound is not necessary unless to diagnose pregnancy, not certain or suspecting ectopic or missed abortion. Next slide. How do we counsel these patients? Thoughts about terminating the pregnancy. You ask them, and what is their reason for terminating? Then inform them early abortion is safe. Importance of a trained provider performing the procedure for safety. What are the methods available? As like a contraceptive cafeteria, you just give all the available methods. Let them choose. We should also tell about the safety, risk and warning signs associated with the abortion method. Without contraception, she can get pregnant as soon as 14 days after an abortion. This is very important. While we discharge them, we have to be careful and tell this instruction. Resumption of her normal activities, including sexual intercourse, any other follow-up care. And most important is documentation. Informed written consent, decision to accept post-abortion contraceptive. Even if she is not willing for contraception, she will be provided with the abortion services. Next slide. Clinical management of abortion, less than 12 weeks, more than 12 weeks. Less than 12 weeks, global recommendation is mifepristone and misoprostol only, vacuum aspiration, MVA. More than 12 weeks, mifepristone and misoprostol. misoprostol only, dilatation and evacuation. We should not say dilatation and sharp curettage. That is, previously we used to say DNC. That term is not now. We have to use as dilatation and evacuation. Next slide. Clinical management of abortion, MMA, that is medical methods. This is for first trimester abortion, and surgical methods, MBA or EBA. Next slide. Mifepristone, as you all know, it is anti-progestin. It inhibits action of progesterone, interferes with continuation of pregnancy. Oral dose of Mefi followed by misoprostol, which is a PGE1 analog. Misoprostol causes cervical softening, uterine contractions, and expulsion of products of conception. All these things, while we give tablet, before giving, you have to inform everything and tell her that she will get a crampy pain and give tablets. Next slide. What are the advantages of tablet misoprostol? The protocols for Mefi and Miso, before that, day 1, we give mifepristone 200 milligram oral tablet. If Rh negative, we'll give anti-D 50 microgram. Day 3, after 48 hours, we'll give 400 micrograms misoprostol up to 7 weeks. 7 to 9 weeks, 800 micrograms, sublingual or buccal or vaginal. If needed, we can, in addition, we can give analgesics, antiemetics, offer contraception. Within day 15, follow-up day, confirm and ensure completion of procedure, offer contraception if not already done so. Next. Characteristics of different routes of misoprostol administration for first trimester abortions. Oral use, pills we give them to swallow. It is recommended up to 7 weeks, 49 days for first trimester abortions. Side effects are diarrhea, nausea, fever, and chills. Buccal, pills are placed between the gums and cheek and swallowed after 30 minutes. More fever and chills than with the vaginal route. Sublingual, pills are placed under the tongue and swallowed after 30 minutes. There is increased fever, chills, diarrhea, and vomiting compared to the vaginal route, but fastest onset of action and highest plasma concentration levels. Vaginal pills are placed in the vaginal fornices. Pill fragments may be visible, lowest rate of side effects. So of all the routes, the side effects are lesser with the vaginal route. Next slide. This is the picture showing buccal and sublingual. You can see the tablets, how they are placed. Next slide. WHO drug regimens, dose schedule for medical abortion. For less than 12 weeks, mifepristone 200 milligrams per oral once, misoprostol 800 microgram given. Vaginal bleeding for 2 weeks is normal after medical abortion. Such bleeding can last up to 45 days in rare cases. Next slide. Provision of MMA services. The services should be available at the primary care level with referral systems in place for all required higher level care. Additional services may need to be provided to individuals seeking medical abortion. Counseling and testing for STDs, abuse support services, psychological or social services, or other specialist health or medical services. You have to give iron tablets if patient has anemia and painkillers. Provide emotional support. Talk to them. Tell them what all the complications anticipated and counsel them properly so that they will not have the fear. Next slide. Follow-up care. Routine follow-up not necessary following an uncomplicated medical abortion using Mefi and Miso. A routine follow-up visit is recommended only in case of medical abortion using misoprostol alone to assess success of the abortion. A follow-up visit 7 to 14 days after the procedure may be offered to provide contraceptive counseling and services, emotional support, or address any medical concerns. Next slide. So any procedure, and if we give misoprostol, follow-up may be necessary, otherwise not needed. Assess for follow-up care, assess women's recovery and ask for any signs or symptoms of ongoing pregnancy, review any available medical records and referral documents, ask about any symptoms experienced since the procedure, perform a focused physical examination for any complaints, assess women's fertility goals and need for contraceptive services if not provided earlier. Next slide. MMA summary. First visit day 1, what we should do physical and pelvic examination, confirm eligibility, whether she's within 7 weeks, give tablet mifepristone 200 milligram oral tablet, offer if she's RH negative anti-D. Tell the woman return for misoprostol administration after 48 hours. Contact address and phone number of the patient, the facility center, where she can go in case of any emergency. This is very important. Record her experience of any side effect on the MMA card. In this card, all these things should be recorded. 3% women may expel completely with mifepristone alone, but misoprostol schedule should be completed. Next slide. Second visit on day 3. We have to give misoprostol 400 micrograms sublingual, buccal, vaginal or oral route, observe for 4 hours, give analgesics, contraceptive options or condoms, hormonal methods. Tell the woman the mean period of bleeding will be for 8 to 13 days. The side effects expected are nausea, vomiting, diarrhea, headache, fever, dizziness. Report in case of excessive bleeding, PV, pain, abdomen and fever. Report if there is no bleeding 24 hours after misoprostol. So they have to report if they have more bleeding, and also if they don't have bleeding after giving misoprostol for more than 24 hours also, they have to report. 75% of women abort within 4 to 6 hours after misoprostol administration. Third visit on day 15, what should we do? Pelvic examination to ensure the completion of abortion. Contraception options, we should offer them. Hormonal methods, condoms, IUCD, sterilization after 1 menstrual cycle. Tell the woman about immediate return to fertility. Report back if there are no periods within 6 weeks of completion of the abortion process. Ultrasound only if examination does not confirm the completion of procedure. Next slide. What are the side effects and complications? They may have pain, nausea, vomiting, diarrhea, infection. All these things are mostly self-limiting and we should reassure them. Next slide. Action for failure or incomplete result of MMA. If failure of MMA, offer vacuum aspiration or repeat MMA. Incomplete result of MMA, observe unless heavy bleeding. If bleeding resolved uterus normal size, we assume that abortion is complete. If heavy, repeat misoprostol if it is incomplete result, or offer surgical method of evacuation if bleeding continues, heavy bleeding continues. Next slide. If there is excessive bleeding, woman presents with excessive bleeding PV, can you enlarge the slide, ma'am? It's not much visible.
Yeah, may not be feasible.
Okay, okay. Women presents with excessive bleeding PV means can you go through, madam? I could not read. If the bleeding continues, ultrasound is indicated. And
Yeah,
look for it.
it's just saying if bleeding decreases over time, then you can just watch vital signs,
Yeah.
examination.
Observe for vital signs, and if there is more bleeding, you do a scan and see for any retained products.
Yes, exactly. If there are retained products, then
and remember that you have to confirm the pregnancy is continuing or not.
yes.
Okay. Next slide.
Just a minute. Now it has.
Yeah, now little visible. Recording and reporting for MMA. Since MMA comes under the purview of the MTP Act. The documentation is similar to that required for the VA procedure. It is mandated to fill following forms. Form C is consent form. Form 1 is RMP opinion. Form 2, monthly reporting form to be sent to the district authorities. Form 3 is admission register for case records. Next slide. Methods of first trimester abortion, surgical methods, MVA, EVA. Next. Surgical methods, vacuum aspiration is the recommended technique of surgical abortion for pregnancies up to 12 weeks. WHO recommends MVA as the safest method. The procedure should not be routinely completed by sharp curettage. This we all know. This is the MVA syringe, all of you know, handheld aspirator used to generate vacuum. Aspirator is attached to cannula of 4 to 12 mm in diameter. Cannula can be used in multiple settings, including those without electricity. EPAS or easy grip cannula size corresponds with weeks. If 8 weeks means we have to use 8 mm cannula. If 10 weeks means we can use 10 mm cannula according to the weeks. This is electric vacuum aspiration, and electric pump used to generate vacuum can accommodate cannula of manual vacuum aspiration with correct size tubing. Previously, we used to do this suction cannula, but MVA is very safe. Next slide. Cervical priming, we can use oral Mephi 200 milligram or meso 400 microgram sublingual 2 to 3 hours prior to the procedure, or meso 400 microgram administered vaginally 3 hours prior to the procedure, or laminaria placed intracervically 6 to 24 hours prior to the procedure. Next slide. For pain, we have non-pharmacological and pharmacological methods. Next. For non-pharmacological, all of you are aware, we have to give psychological support, explain each step to the woman in advance, perform the procedure gently and smoothly, encourage the woman to relax and breathe deeply. Pharmacological pain management, anxiolytics we can give for cervical dilatation, lignocaine local, and for uterine cramps, you can give Brufen 400 to 800 milligram 1 hour prior to the procedure. Next slide. The steps of MVA. So prepare instruments, prepare the woman, ensure pain control, ask her to empty bladder, perform cervical antiseptic preparation, administer paracervical block, dilate the cervix, insert cannula, and evacuate her. Suction of uterine contents, withdraw cannula 1 to 2 centimeter away from the fundus inside the uterine cavity, rotate the cannula in 10 to 2 o'clock position with smooth, gentle motion, release the vacuum button on the aspirator. Next slide. Signs that the uterus is empty, red or pink foam without the tissue passing through the cannula, gritty sensation over the surface of the uterus, cervix gripping over the cannula, uterus contracting around the cannula, increased uterine cramping. Inspect tissue. Concurrent procedures, proceed with contraceptive methods such as sterilization, IUCD insertion. Instrument processing, we have to soak it in 0.5% chlorine solution. Helps remove tissue and body fluids. Next. After the procedure, monitor her for any complications and provide management. She may leave the facility when she is stable and meets the criteria for discharge. Ensure that the woman has all necessary information and medications prior to leaving the facility. Document all outcomes of the treatment, including any adverse effects in the facility register and client's record card. Next slide. Aftercare, management of abortion complications. See for any, if there is any incomplete abortion, any infection, bleeding, or ongoing pregnancy. Provision of contraceptive information and offer contraceptive counseling and methods. Assessment of any other sexual and reproductive health needs that may require additional care. Follow. No routine follow-up unless meso alone regimen is used. This is new recommendation. All of you should be aware. Summary. India has made historic progress in improving access to a safe abortion. Not much has changed in technological update in the last decade. As providers, it is up to us to ensure safety and quality, especially in context of the amended law. Along with safety, we also need to focus on respectful abortion services. Every client, public or private, an opportunity to inform, educate, and equip with proper information on contraception and counseling. As Dr. Vidya Tobe said, you have to do pre-test and post-test and feedback for certificates. I think I have completed Safe Abortion Services. I will give my mail ID in the chat box. You can ask your queries. Thank you, ma'am.
Thank you, Geeta ma'am. Thank you so much for the very informative talk. I would now like to welcome our next guest speaker, Dr. Anjali Ganharimam. And her topic for today is WHO Saver Toolkit, Safe Abortion Values, Evidence and Rights. Welcome, ma'am.
Thank you, Dr. Neha, for giving me this platform. Just give me a minute. I'll start sharing the module with you all. Is it visible now?
No, ma'am.
Just give me a minute. Just a minute, please.
No problem. Thank you.
Actually, I'm not able to go back to my screen. So just a minute, please. Neha, is it visible for you to, is it possible for you to do the sharing? Just otherwise.
Yes, ma'am, I'll do that.
I'm just trying to go back, but I'm not able to go back on my screen.
Ma'am, I'll do that, ma'am. I'll do that for you. Document.
So I think we all are aware why we all are sitting together at this time to make ourselves aware about what are the changes which the new MTP Act is going to bring into our services as a provider for medical abortion or abortion to a patient. Have you started with it? Yeah, just let me. Yeah,
I'm
just
not able to, ma'am. I'm trying. I'm not able to. I'll let you know, ma'am, once it starts.
okay. In between, maybe even I'll try to.
ठीक है बेटा कर लेने दे तू करेगी
It is again and again coming to Zoom sharing only.
I'm not able to go to the Zoom screen also, actually. I don't know what's wrong.
Am I visible now, ma'am?
No, I can't see anything on my screen. I can't do anything about it.
Ma'am, if you want to start, you can start without sharing the slides. Meanwhile, I'll try to share your presentation, ma'am.
Yeah, I'll just start talking about it and then maybe we can take it from there. Maybe you can start sharing it as it comes to you. Just give me a minute. I'll go back and do it once because now I can't even move my screen to see anything around.
Is there anything visible now?
No, at least I can't see. Yes, something is visible now. Are you changing it or am I changing it?
I had started sharing my screen.
Okay.
Sure.
So have you been able to share screen?
It's not visible, madam.
No, ma'am.
Because I had stopped sharing screen option on my end, and I think I didn't log into it again. That's why I'm not able to go back to Zoom also. But is it okay if I continue with the module? At least now I can see the module with me.
Yes, ma'am. Yes, ma'am. Please.
So the module 3 shows safe abortion values, evidence, rights, and respect as SAVER. It is SAVER, safe abortion values, evidence, rights, and respect. Respectful abortion care is a joint FOXI and WHO initiative, and we are here with the Master Trainers Orientation Virtual Program, which was started in January 2022.
Anjali, madam, sorry to interrupt you. Shall I share the screen, madam?
Yes,
From
please
my
go
end?
ahead. Please go ahead.
Just a minute, ma'am.
Yeah. Just let me know when you are able to start screening.
Madam, I think you can go on if you are comfortable. And if he starts the slides, you can continue then.
Okay, so we'll take it from there.
Share the screen, ma'am.
No.
So actually, this module aims to define respectful abortion care as per WHO.
Yes, it's
standards.
visible now.
Okay.
Madam,
So it highlights how norms and stigma can affect services and provide WHO saver resources for RAC. Next, please. The momentum has been created. Law has changed. Dissemination needs association and OB/GYN provider support. FOXI, as we all know, is the largest provider base for abortion care. They have online training possible due to COVID. Respectful abortion care can reach all providers. MMA uptake has increased. We all are aware about it. It is early, safe, ensure no PCP and DT complication, and we all are using it day in and day out. Patient safety, respect, and quality matters more than ever, and we all have a role to play. Next, please. The law changed on 25th of March 2021, and the rule changed on 24th of September 2022. So now it is a rule, and we can't take any chance to miss what the rule has to say for us. So what is respectful abortion care? It is adopted from respectful maternity care, recommended by the WHO. Respectful abortion care is the care that maintains safety, dignity, confidentiality, ensures freedom from harm and mistreatment, and enables informed choice and continuous support during and after all types of abortions. Next, please. So what is respectful abortion care? In simpler terms, respectful care means you as a provider or me as a provider or as a patient treat and are treated with dignity, empathy, and compassion, regardless of your race, ethnicity, gender, socioeconomic status, or reproductive history. Number of pregnancies, miscarriages, and abortion. If you ever feel that something isn't right, speak up. As health professional, it is our duty to listen and support. And communication is the key. Next, please. So what are the norms and stigma? Norms and stigma perpetuate disrespect and abuse. There is category of disrespect and abuse. It could be a physical abuse like slapping or intimidating physically. Verbal abuse, non-consented care, shouting, screaming, sexual abuse, abuse of power, taking advantage. Stigma and discrimination, failure to meet professional standards of care, poor rapport between women and providers, health system conditions and constraints. Right of every woman is freedom from harm and ill treatment. Right to information, protection under laws. We all are aware about the MPP law, the POXO law, informed consent and refusal, respect for choices and preferences, dignity and quality of care, right to timely healthcare and to the highest attainable level of health, liberty, autonomy, self-determination, and freedom.
Madam, shall I play the video, madam?
Yeah, please. Let me know, because I can't play the video and I can't speak about it.
Social norms are the unwritten rules of behavior that are considered acceptable in a group or society. Norms can change according to the environment, situation, and/or culture in which they are found. People's behavior may also change accordingly. What are some examples of social norms? In times of COVID-19, there are new social norms that are considered COVID-19 appropriate behaviors like wearing a mask, maintaining social distance, and to wash or sanitize our hands regularly. An example of a social norm that we must follow at all times is to not use profanity in conversation, especially formal or official conversations or when talking to patients, clients. Now let's look at some examples of social norms around gender. Girls wear pink, boys wear blue. This is a gender stereotype. Girls and boys can choose to wear whatever color they like. Color has no gender. Men should be working, strong, and not show emotion. Women should be caring and nurturing and stay at home. Men should work and make money. Women should take care of housework and children. There is no need for women to own or inherit property. Now let's look at a few examples of norms around sexual and reproductive health. Just as norms around gender are smaller aspects of some broader social norms, norms around sexual and reproductive health also trickle down from certain norms around gender. According to the WHO, good sexual and reproductive health implies that people are able to have a satisfying and safe sex life, and that they have the capability to reproduce and the freedom to decide if, when, and how often to do so. A woman should be married before getting pregnant and having children. Adolescent sexuality and premarital sex are unacceptable and immoral. Women are responsible for contraception. Now we see what is stigma. Stigma can be understood as a shared understanding that a person, a quality, or circumstance is somehow morally unacceptable. What are examples of sexual and reproductive health stigma? A shared understanding that sex before marriage is morally wrong and/or socially unacceptable. A girl who uses a contraceptive method is promiscuous and will have problems when she decides to get pregnant. A married woman is more deserving of contraceptives than an unmarried woman. A girl who has had an abortion is committing a sin and brings shame to her community. Having an abortion has long-term health effects, and the woman's health will never recover to her pre-abortion state. Women who have had an abortion once would become habitual and avoid using contraception. It is important to understand that norms and stigma are different from laws and policies. For example, an unmarried girl seeking abortion is considered immoral due to stigma, whereas, as per law, sex-selective abortion is illegal in India. In this exercise, we explore how social norms and stigma influence access of reproductive health and rights, how people experience SRH stigma, the impact social norms and stigma have on our actions personally and professionally, and the impact they have on the actions of others personally and professionally.
So shall I continue?
Yes, ma'am.
Okay. So what are the domains of respectful abortion care? There are 12 domains of respectful abortion care: being free from harm and mistreatment, maintaining privacy and confidentiality, preserving women's dignity, respecting women's choices, engaging with effective communication, soft skills, providing information and seeking informed consent, ensuring continuous access to support, enhancing quality of physical environment and resources, providing equitable abortion care, availability of competent and motivated providers, provision of contraception advice and commodity security, and continuity of care and counseling. Next slide, please. So this is time to strengthen implementation. The changes which have taken place in the new amendment are: every patient is an opportunity for respect, and as provider, onus is on us to educate and also reduce sex-selective abortions. One provider, more responsibilities: counseling, contraception, referral, and compassionate care. Expands eligibility, especially young people, survivors, unmarried, everyone needs unbiased care, and we need to overcome our own biases. 20 to 24 weeks for special cases, need for sensitivity and judgment-free timely services, and prioritize confidentiality and safety. Respect, baggage respect. As providers, we need to be mindful of socio-cultural aspects which are there in our society. Next, please. Guide to avoiding stigmatizing language. WHO training for safe abortion values, evidence and rights. The SAVER toolkit is there to help us out with this.
To an unsafe abortion. And when abortion is provided, it should be given in a legal and evidence-based manner with quality, safety, dignity, and respect. WHO has a toolkit on safe abortion values, evidence, and rights, or WHO SAVER, which is a module-based training for doctors, nurses, health providers, program managers, and really anyone.
Should I play the video, madam?
Yeah, is the video playing?
And learn together.
No, madam, we can't see you because I am sharing the screen, right?
No, you need to play it because
During the COVID-19 pandemic,
I just can't do anything on the screen.
the WHO SAVER
We can see the video. We can.
gamified hybrid version that you can do either in person, online, or as a combination with an expert trainer, or simply by playing one of the standalone games to learn from the comfort of your home. Perhaps four modules. Engage.
The audio is not very clear.
Yeah, so there are 4 modules actually. Module 1 is engage.
Stories from the country
It can just tell you about what is happening recently,
the realities of safe and unsafe abortion.
about safe and unsafe abortions.
Standard definitions. In the inform module,
The second module is inform module.
The audio is not very clear. Shall we skip the video and you can tell us the summary
Madam,
of
I'll share the video, madam. I'm sharing my screen, right? I'll share
The
everything.
IT person will have to play the video also. I just can't do anything.
More than I'll share the video, madam.
watch videos relating to gender, safe abortion, preventing unwanted pregnancy, explore social norms and values, and consider how these may be rooted in stigmatizing attitudes or contribute to stigma from a personal perspective. The equip module is to promote knowledge.
The third module is equip module.
And further use of WHO guidelines and tools, with a focus on guidelines and tools relevant to contraception.
It focuses on
abortion,
guidelines and
post-abortion
tools
care.
on contraception and post-abortion contraception.
But now we can see just one slide saying guide to avoiding stigmatizing language. We are not able to see any video.
Slides nahi aa rahi.
No one behind.
We cannot see any video. We can just hear the audio, and there is
That's what
only
I'm
one
saying.
slide.
That's what I'm saying, madam. If you stop share, I meant to say mute yourself, then I play the video.
With ensuring safe abortion is provided with values, evidence, and rights or respect.
Hello, madam.
Huh?
Please mute yourself, madam, so that I play the video.
No,
I'm sharing
I just can't do anything on my laptop. I'm stuck. Let me finish this off, and then if we have time, you can play the video.
I'll play the video, ma'am.
Huh?
Shall I play the video?
Yeah, I think I just have 2-3 slides. Let me go through them, and then you can play the video. So actually, there are certain games which have been given, and there's the mail address which is there on by which you can link to the games. And I think we'll just talk about the recap questions which are there. According to the World Health Organization, restricting access reduces the number of unsafe abortions. You must have done this question in your pre-test. So now you need to go back and recheck whether it is true or false. The answer is false, because unless and until the abortion is safe according to the WHO by appropriate methods and by trained person, it's not considered as safe. So restricting access reduces the number of unsafe abortions. This is a false statement. A 30-year-old woman recently widowed wants to get an abortion at 22 weeks. As a provider, it is your responsibility to tell her to continue this pregnancy. If your answer was probably yes, then you need to really go back and look into it, because the answer is no. You are there to provide her with the services. So it's not your responsibility to tell her to continue this pregnancy. She has come to you with a decision made. So you need to give respect to her decision. In India, abortion is legal. Let us make it safe and respectful. By Samarth. Samarth is safe abortion made available respectfully throughout health system. Samarth Bharat, Sampurna Bharat is the logo, and this is the vision of our President, Dr. Shanta Kumari, to spread this to everyone around and make things easily available to our people who are in need of abortion services. So at least now I can see something. If you want to go ahead and play the video, maybe it is upon you.
How to talk about abortion, a guide to right-based messaging. Abort a child is medically inaccurate as the fetus is not yet a child. Terminate a pregnancy is commonly used. However, some people prefer to avoid this as terminate may have negative connotations for some people. For example, terminator or assassinate. In some contexts, the word abortion can be perceived as negative. In these situations, it may be helpful to avoid the word completely and use termination of pregnancy instead. It is important to be legally accurate, and in India, abortion is legally permitted to the full extent of the law. However, in many parts of the country, the barriers to access may be so great that abortion is considered by many to be illegal due to conflations with other laws. Make sure that you share accurate information about the legal situation and make the circumstances under which abortions are legal clear. See the WHO Global Abortion Policies database for information on the legal status of abortion across the world. Let us look at some stigmatizing words and how to avoid them. Abortionist is a term used by those opposed to abortion. Healthcare provider is usually a more accurate term to use than abortion provider, as most of those providing abortion care also provide other health services. In India, they are also called RMPs or Registered Medical Practitioners. The preferred terms are medically accurate as the embryo or fetus is not a baby. When referring to the tissue examined following a surgical abortion, an appropriate term is products of conception. However, this term is only useful for materials focused on medical details of abortion, as it is not commonly used or understood outside of medical or scientific contexts. Conscientious or moral objector implies that those who do provide abortions are not conscientious individuals, which is incorrect. Refusal to services must be well founded. For example, sex selective abortion in India is illegal. This tends to suggest an act of wrongdoing, placing unwarranted blame on the woman and frames parenthood as punishment. The right to abortion should never be linked to how or why a woman becomes pregnant. Abortion is a woman's right and choice. Consider the classification of pregnancies into the categories unintended, unplanned, unwanted, or mistimed. The classification relies on a framework that assumes that pregnancy is, should be, or even can be a conscious decision. The complexity and possible ambivalence of pregnancy intention, as well as the dynamic nature of childbearing decisions before, during, and even after pregnancy, are not accommodated in these classifications. The suffix "side" denotes killing, which is not appropriate when describing abortion. When referring to sex-selective abortion, it is more accurate to describe the practice in terms of choosing to end the pregnancy based on the predicted sex of the fetus. Make it clear that abortion is about making an informed decision, and avoid the implication that ending a pregnancy is done without careful thought or consideration. The term keep implies a positive outcome, which may not accurately reflect the situation. In addition, it is medically inaccurate to describe the pregnancy as a baby or child. It is more accurate to describe the situation as a pregnant woman choosing to continue with the pregnancy. Late term could refer to any time in the second or third trimester. Instead, if necessary, use terms that indicate the specific trimester or gestation. Use of late may also imply that a woman is late and thus irresponsible in seeking an abortion. For example, there is no gestation limit for birth defects and associated abortions in India as per the recent MTP amendment of 2021. Use of mother, father, parent during a pregnancy is value-laden and assigns roles that the man or woman may not accept. It also implies that the fetus is a child, which is not accurate. Also, under the MTP Amendment 2021, in India, any woman and her partner, married or unmarried, can seek abortion. Abortion is not contraception. Contraception is to prevent a pregnancy, whereas abortion is to terminate a pregnancy. People often seek abortion due to the occurrence of an unintended pregnancy or for health reasons, and there will always be a need for safe and legal abortion. All reproductive choices and care should be available and supported. People should be supported to prevent unintended pregnancies with access to contraception and accurate information. Pro-life implies that those who support legal abortion access are anti-life, which is inaccurate. Instead, use alternative terms to make it clear that you are referring to individuals opposed to anyone having an abortion. Where possible, our language should reflect the fact that we are service providers with a focus on providing rights-based quality healthcare and support. In order to dispel myths about organizations that provide abortion care, it might be useful to avoid business-related language. Multiple and repeat can have negative connotations, such as repeat offenders. Multiple and repeat also imply that each abortion experience for a woman is the same, whereas each abortion is surrounded by a unique set of circumstances. If safe, what is wrong with having multiple abortions? Because abortions happen under a wide range of cultural, legal, and medical circumstances, It is important to be careful about the terms that you use to avoid mixing up terms and creating confusion. Here are a few phrases to be aware of. Illegal abortions are those that do not comply with a country's legal framework but may be safe if performed by a trained provider or when a person has access to high quality medication, information, and support to safely undergo a medical abortion in a safe and licensed place. Remember, abortion is considered safe as per WHO guidelines when the 3 P's provider, place, and process are safe, trained, and certified. Unsafe abortions are performed by providers who are not registered or trained, or in situations where people are unable to safely undergo a medical abortion due to lack of access to high quality medication, information, or support. It is possible to have an unsafe legal abortion. Unwanted pregnancy is a pregnancy that a person decides they do not desire. Unplanned or unintended pregnancies refer to pregnancies that occur when a person is not trying to get pregnant. An unplanned or unintended pregnancy may be either a wanted or unwanted pregnancy. In India, abortion is legal, but sex selective abortion is illegal. Provider and place need to be safe, trained, and certified.
There is another video, madam. Madam?
Yes, sir.
There's another video to play, ma'am. I'm playing the video.
Yes, you can play that also.
No woman should die due to an unsafe abortion. And when abortion is provided, it should be given in a legal and evidence-based manner with quality, safety, dignity, and respect. WHO has a toolkit on safe abortion values, evidence, and rights, or WHO Seva, which is a module-based training for doctors, nurses, health providers, program managers, and really anyone to assess our values, address our biases, and learn together to transform our attitudes towards respectful abortion care for anyone who needs it. During the COVID-19 pandemic, we adapted and converted the WHO Seva Toolkit into an innovative, gamified, hybrid version that you can do either in person, online, or as a combination with an expert trainer, or simply by playing one of the standalone games to learn from the comfort of your home. Seva has 4 modules: Engage, Inform, Explore, and Equip. In the Engage module, participants review recent media stories from the country about gender, unintended pregnancy, the realities of safe and unsafe abortion, and juxtapose these with the global standard definitions. In the Inform module, participants share and discuss background information on SRHR, on safety of legal abortion, contraceptive prevalence, abortion incidence and safety, abortion law and safety, and achieving reproductive rights in the global and regional or local context. In the Explore module, participants will play various games and watch videos relating to gender, safe abortion, preventing unwanted pregnancy, explore social norms and values, and consider how these may be rooted in stigmatizing attitudes or contribute to stigma from a personal perspective. The Equip module is to promote knowledge of, interest in, and further use of WHO guidelines and tools, with a focus on guidelines and tools relevant to contraception, abortion, and post-abortion care, towards the many steps needed for achieving the Sustainable Development Goals, also known as SDGs, building resilient health systems for universal health coverage, or UHC, leaving no one behind. We must remember quality and dignity of care matter as much as saving lives. Seva is our small step towards SDGs, starting with ensuring safe abortion is provided with values, evidence, and rights or respect.
So that is basically about the Saver toolkit, which is there with the WHO training. So that
Done,
was
madam.
all about module 3. So I think I can stop here, and Dr. Neha.
Thank you.
Yeah,
Thank you, Anjali ma'am. Thank you. That was a very nice, very elaborative talk. I request our next guest speaker for today, Dr. Tarveen Singh, sir. He'll be talking on pre and post-abortion family planning counseling. Welcome, sir.
Hello, Dr. Neha. It's a she, not he.
Oh, so sorry, ma'am. Your video was off till now, na?
I was listening. I was on in between, but then I was just listening to all the talks.
I would have never confused such a pretty lady for my name.
All right. Thank you so much.
Welcome,
so without,
welcome.
yeah, thank you. Without much delay, I think we, should just start. So I go to. Is that good enough for everybody to see?
Yes, ma'am. Very nicely visible.
Yeah. So you can call me Dr. Tanveer. So now going to an extension of module 3.
It's not in a slideshow, madam.
Pardon?
It's not in a slideshow. Click on the slideshow button.
Okay. All right. So an extension of module 3, we are going to take it forward and talk about the pre and post-abortion family planning counseling, and also talking about how we can improve on our online consultations and referrals. So I would like to thank Shanta Kumari ma'am and Dr. Madhvi ma'am for this opportunity and for doing such good work, especially in respectful abortion care. So what is counseling? Counseling is a structured interaction in which a person voluntarily receives emotional support and guidance from a trained personnel in an environment that is conducive to open sharing of thoughts, feelings, and perceptions. And for a woman, there's no better place than to come to a gynecologist for counseling. Pre-procedural counseling has a very critical role. It helps women to decide about termination of pregnancy. As gynecologists, as healthcare providers, help women to choose the method of contraception or termination, and we can ensure that delivery of complete information about the procedure offered to the women, and also help them to adapt or adopt a appropriate contraceptive method. So how do you do it? Most importantly is ensure privacy and confidentiality. Now we understand why privacy and confidentiality is important, because of the stigma surrounding the abortion. Be non-judgmental and be sensitive. Establish a good rapport. Use simple language and allow the woman to clarify her doubts. And if she has made up her mind for termination of pregnancy, assess her for the procedure. And as rightly said, it is not our responsibility to push them to continue the pregnancy. Yes, maybe it's our responsibility to advise them, but it is their decision in the end. So relevance of peri-abortion family planning counseling is important, because we need to tell them about the quick return of fertility, the opportune time for contraceptive acceptance, and to give a gap of at least 6 months before they think of next pregnancy, and the health benefits and better future pregnancy outcomes. As we understand, 90% of abortion-related maternal mortality can be prevented by ensuring contraception. Pre-abortal family planning counseling, when do we start? Ideally, first visit at first consultation, when they come for a medical termination. That is when you could talk about it. You could delay the counseling if they are in grief or they do not want to talk about it at that moment, but it's a good idea to offer them. What to counsel? The importance, the return of fertility within 10 days to 4 weeks, help with the choices, method-specific counseling, and high-risk behavior, to understand their high-risk behavior and counsel them about maybe minor changes in, what is required. If the woman is not willing for any contraceptive method, do not refuse medical termination of pregnancy. Try and counsel her after the procedure. And if she's still not willing, it is a good idea for a follow-up in a week's time and counsel. I know cost is a big stop over, and also there's a lot of stigma surrounding counseling. A lot of women don't want to go for it. And I think main part is lack of counseling. So every opportunity, please do counsel women on contraception. Assessing suitability for post-abortion contraception. General guiding rules are abortion process. After the abortion process is complete, there should be no infection, no injury to genital organs, and chances of fresh pregnancy is ruled out. Post-procedural counselling also has a very critical role. Ensure women has understood precautions and care needed during the post-abortal period, opportunity to counsel for contraception in case not previously accepted, reinforce the need for continuing the use of contraceptive method chosen. The procedure is post-procedural counseling procedure is to continue, reassure, and to repeat. Continue the privacy and confidentiality. Reassure her in any case of problems, like sometimes you may have with the IUCDs, they may have spotting, they may have slight pain or a prolonged period. Reassure them that it's okay, when it's not, and repeat the information about post-procedural care and danger signs. Post-abortion family planning counseling, when they've already opted, appreciate that they have come informed, give them immediate care, ongoing, if they are ongoing pills, you can continue, follow a protocol for follow-up, ask them to come back, whatever your protocol is, continuity, and give them cards or to maintain the menstrual cycle and etc. If they are undecided, first try to calm them down, allay the anxiety, importance, tell them the importance of immediate abortion and chosen extended period of abortion, couple counseling, and emergency contraceptive pills. Post-abortion contraceptive methods, available methods are barrier methods in the first trimester, following first trimester or second trimester. So condoms, it can be used as soon as sexual activity is resumed in both the first and second trimester. The advantages are no hormonal side effects, can be used without consulting a health provider, easily available, prevents STIs, and enable men to take responsibility for contraception. For intrauterine contraceptive device, it is inserted immediately or up to 12 days after confirmation of completed abortion using a surgical method. Whereas with medical abortion, it is inserted around day 15 of the process, and provided there is complete expulsion of products of conception, confirmation of complete expulsion, and there is no infection or any other contraindication is ruled out. In a second trimester, it can be inserted immediately or up to 12 weeks after the procedure. And yes, obviously, you rule out any contraindications, make sure that there is complete expulsion of products of conception. It is highly effective, provides long-term contraception for up to 5 years or even up to 10 years, can be used provided by trained doctors, ANMs, nurses after first trimester, surgical abortions, and by trained doctors after medical abortions, and even PPIUCDs by trained doctors after second trimesters. There's no interference with sex, immediate return to fertility on removal, and no hormonal side effects. In hormonal contraception, long-term injectables are given, medroxyprogesterone acetate, immediately or up to 7 days after abortion using surgical methods. With medical, it can be started on day 3 with a dose of misoprostol. In a second trimester abortion, it is given immediately or up to 7 days after abortion. It is highly effective, confidential and private, can be used again by doctors. There's no interference with sex, no effect on the quality of the milk or the quantity of the milk. There are no estrogenic side effects, and offers protection against ectopic pregnancy, ovarian cancers, iron deficiency, and uterine fibroids. Return of fertility takes about 7 to 10 days after the injection given. So that is something which you have to inform these women. So permanent methods are female sterilization and vasectomy. Female sterilization following first trimester can be performed after an abortion in the, again, absence of infection or severe blood loss. It can be done concurrently or up to 7 days. Both mini-lap or laparoscopic sterilization can be done. With medical termination, it can be done only after the first menstrual cycle. In the second trimester, mini-lap sterilization can be performed concurrently or up to 7 days after an abortion in the absence of an infection or severe blood loss. Lap sterilization is not recommended after second trimester. Ideally, it's better to wait for a couple of months before you go ahead. The advantages or additional information about female sterilization: it's a permanent method, highly effective. It is effective immediately. There's no interference with sex, no effect on breastfeeding, no long-term side effects, and it offers protection against ovarian cancer. Whereas vasectomy is concerned, it is performed on males independent of timing and procedure of the abortion. They could do it anytime. Very effective, again, permanent method, no interference with sex, no long-term effects, but couple must use another contraception at least for about 3 to 4 months. Now, with medical termination, medical abortions, oral contraceptive pills, injectables, IUCDs can be used almost immediately. It works well. Whereas in following vacuum aspiration, it can be given up to 7 days. Within 7 days, injectables or even IUCDs or even ligation can be done. Now coming to sexual reproductive health services, teleconsultation and other technology. So when we talk about this, when we talk about these services provided, teleconsultation, especially in the era of COVID, I think there's been a big boon. It's existed for many years, but it's never been used to the level that it's being used today. Telecounseling, teleguidance, referencing, and linkage. So the website available online by the National Health Ministry is HUMDO, where all details are available about family planning counseling. Social media, Ask Tanu, that is with Foxy. Ask Tanu is also a big hit. So any information you can ask women to go to the YouTube, go to Ask Tanu on social media and have any information they require, showing them different infographics, as you can see on the slide here, use helplines, and also and patient education platforms such as WHO, RCOG, and MFW. Now, the strength of this teleconsultation is in the COVID era, approachable throughout the process, that it gives them confidence because you're approachable, awareness, very important. The questions are given out, the answers are obtained at ease. The weakness is there is no personal touch. So there's no face-to-face and there's no demonstration. Opportunity is privacy and comfort is maintained. Definitely it's cost saving. It cuts down on the number of visits. The threat, it's a missed opportunity and sometimes can lead to misdiagnosis. Applicability of components of comprehensive abortion care, it can assessment, counseling, and follow-up. So it can confirm diagnosis, contraceptive need, video conferencing can be done, and in follow-up, we can provide hybrid services that after a online consult or video counseling, you can call them back for 1 visit, or after medical termination, they can come back for 3 visits spaced out. So you could assess and treat them well. The key messages from this talk, of the whole talks, are to realize the need for post-abortion family planning counseling, bring the couple on board and strive for 100% coverage. In today's time, with the telephones available, with emails available, I think it's not very difficult to do a follow-up. Inform the patient, empower the woman and the husband. Capitalize on the basket and applicability of the post-abortal period. Technology, use the technology as far as possible. Scope for entry in these comprehensive abortion care services. Concerns about the policy. So yes, there can be concerns about some malpractices, but if it's done in protocol based, I don't think that's a problem. Know your limitations to what extent it can be done. Service costs are actually cut down, and adolescent reproductive health needs both online and offline consult. So yes, register. I hope you performed your pre-test and done your post-test. So your certificates will be awarded online following it. Thank you.
Thank you very much, ma'am.
So any questions are welcomed, whatever we can help.
I'll check the chat box. I think Foxy is working so hard on this RAC project that almost all queries are gone.
Yeah, it's excellent. Actually, I mean, in India, I think we are so progressive and we are so open. I mean, we should be very thankful to be living here and, working here, because it's not so easy living in other parts of the world where abortion is considered such a big crime and stigma. I think I was in US for a bit, and there when I just spoke about abortion to one of the doctors, they were so upset. They wanted to shush it and didn't talk about it. In that particular area, a doctor was actually shot in a church because he was known for performing abortions. It's really sad. So, yeah.
Even there was a story, earlier a dentist, she was not provided abortive care and she died because of sepsis and all.
Yes, that was, I think, somewhere in the Europe.
Yes, somewhere.
Hello, Dr. Manisha. Very nice to see you at last. I'm looking forward to meet you all in.
Same here, Dr. Tanveer. I was also confused, same like Neha.
Yeah.
But when I spoke to you, I came to know.
Yes.
Ma'am, you must keep
very informative talk, madam.
Yeah. But I've not done the work. Somebody else has done the work. Actually, my video was on in between, but I guess so many participants know I may have been lost somewhere.
Yeah, maybe. Actually, someone was sharing Anjali ma'am's slide, so I thought he is Dr. Tanveer.
Okay. And you can call me Tanveer, no problem.
Yes, ma'am. Nice, ma'am. Nice having you here.
Very happy to be here.
Thank you. Thank you so much.
Thank you, ma'am.
Madam, I'll share sorry to interrupt you, madam. I'll share the post-test and feedback link in the chat box, madam.
Yes.
If you just click on the link, you'll be redirected to the post-test and feedback. Answer all the questions, submit, and we'll get the feedback and we'll issue the certificates as early as.
Yeah.
Right. Thank you. Thank you so much, Mr. Shriman.
Thank you, ma'am.
I take this opportunity on behalf of Ratlam and Ujjain Obs-Gynae Society. I'd like to thank our President, Dr. Shanta Kumari ma'am, our Secretary General, Dr. Madhuri ma'am. Wholehearted thanks to all our guest speakers, Anjali ma'am, Vidya ma'am, Geeta ma'am, and Tanveer ma'am. Thank you so much for sparing your time, and thank you so much for all the lovely talks. Thanks to all the delegates for attending this session. Hope to see everyone soon.
In AICOG, yes.
Yes, sir. Bye-bye.
Okay, bye-bye.
Please complete the post test and submit it. Then only we'll get a certificate.
इसमें वो क्यों नहीं आ रहा है?
क्या नहीं आ रहा है?
Chat.
There will be post test of.
Please go in the chat box. There is a link given there. You click on that and you will go to the test then.
Okay. Done.